everyone. Welcome to, my 16th episode with ESRD, NxStage renal disease. And I want to talk to you today about, first, two things. There's been a change in the way we test for chloramine on the Pureflow, so I'm going to show you the new way. And also, I want to talk to you about what happened with the surgery. Now, you know, on the previous video, I mentioned what happened when I woke up with that pressure and that kind of strangulation feeling. I went to the Jewish hospital and blah, 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 and ended up walking out. And I pretty much, once they did the EKG and I knew it wasn't my heart, I wasn't having a heart attack, I pretty much knew they weren't going to be able to help me. I pretty much connected the dots and realized that my issue was with the venous. And that's probably what brought on the anxiety attack, is because I knew, and I'm sitting there and no one's around, and you know, I just had to make a decision, quick, fast, and hurry, because then restless leg syndrome kicked in, and it was horrible. And they weren't doing anything for me. I was at 4 hours and nothing after the attack initiated. But anyway, my point is that I knew that they weren't going to be able to help me, because I knew it was my fistula. It was fistula related, and in particular my venous side of the fistula, which is the upper part. Okay, and I got a report back, and I went to go see. I had my first appointment with the nephrologist over at the clinic, Dr. Shammy, and great guy, and I mean doctor, great professional, great bedside manner, just so personable and very caring. I come to trust his judgment on things, and kind of rely on them now. You know, his advice. He always gives the options. He tells you the truth about, you know, hey, if you do this, you know, this is the downside, and there's certain things that he's steadfast against doing, and I take that seriously. You know, when a nephrologist is steadfast against a procedure or some kind of a process, you listen. But anyway, and so I went to go see Dr. Shammy on my follow-up, and he said he's very proud of me and blah, blah, so everything, you know, it's going good in that respect as far as how, you know, this process and the transition from clinic to home hemo is going, you know. But I was telling him what happened with the episode that I had, and that where I had to go to the hospital. I told him everything, very clear and honest. Of course, you have to be with your medical team. And I told him that I walked out because I felt that they weren't going to be able to help me, number one. Number two, I was having an anxiety attack and a restless leg syndrome attack simultaneously, and they weren't helping me at all. They wouldn't bring me all I asked for was a cup of coffee, because I knew that that would calm me down, that would offset the attack, especially the anxiety, you know. The restless leg syndrome, I needed to crunch on something. So I asked them if they, you know, I was looking for a bag of pretzels, anything. You know, I know how to take care of these because it's not my first merry-go-round on this, you know. This is what I dealt with on the chair at the clinic. I would bring in my snacks to distract me from restless leg syndrome. And then I think I had an anxiety attack just one time, but I always did bring a thermos of coffee to offset that. That's what works for me, okay? Outside of a sedative or medication of some type. That's what works for me. And if I can use a natural thing that helps as opposed to medication, I'm going to do the natural. So that's all I was asking for, and no one listened. No one adhered or even attempted to try out my suggestions that have been proven to work for me. Anyway, so I explained all that to him, and this was pre-surgery. I think it happened the weekend before surgery. I was scheduled for Tuesday. Might have been, was it Tuesday? I think so. Anyway, yeah, I was scheduled for Tuesday surgery, and this happened on Saturday, well, Sunday early morning, Saturday after midnight. So anyway, so I explained that to him, and then he asked my nurse to get the report, because I saw Dr. Shammy after surgery, and he asked the nurse to go get the report, and they had scanned it into their system, so he gave me a copy. And I was telling him what had happened. I told him what had happened, and that pressure, that ache in my shoulder, and then all across my chest, and then up to my neck, to the point of, I felt strangulation, and then I was getting severe migraines, which I don't get, and it was coming up the side of my head, and there was a spot right here that I couldn't even touch. It was so tender, so painful to touch, and I knew it was venous related. I knew it was fistula related. I knew that's why I was having those infiltrations. Let me tell you a little bit something about infiltrations, okay? They are extremely painful. I think I've explained this before, because when the needle infiltrates, that means that let's say this is the fistula. It cuts through the fistula. The needle misses. It punctures through the fistula. So that blood, that clean blood that's coming out, is just spilling all right there. And that balloons up because it fills up in one area. It doesn't flow anywhere because it's not riding in a vein, or it doesn't have an avenue where the heart is pumping it out anywhere. So it's just a buildup in one spot of blood. And it's extremely painful. It swells up real fast. And it also bruises pretty quick. So painful. Plus then you have that needle in there too, 15 gauge. Yeah, not to mention the puncture to the fistula, that's painful. You feel that. You feel it's like a tear. But anyway, I have a picture of what an infiltration looks like, okay? This is the procedure though. Before they can't just take the needle out. They have to put another one in, connect the line, and then take the dead line out. The one that's pounding at you with pain. So it's extremely painful, and you're sitting there just want to jump up and run because of the pain, and you can't. You've got to sit there and wait until they get the syringe, clean the spot, put it in, bleed it back, connect the lines, and then, change gloves, and then take the needle out. And when they take that needle out, that relief, wow, it's heaven. But then you're left with the soreness, and the tenderness of the infiltration itself. And you have to wait. You have to wait. I've learned that when the needle infiltrates, just take it out. Don't try to put in another one. Stop the treatment. Because my surgeon says when you infiltrate, you have to wait at least 10 days for that to heal, that fistula to heal. That blood to dissipate, the swelling to go down. Yeah, you do ice packs and all that right away. It takes time for that swelling to go down. And then that blood buildup around the fistula puts pressure on it. Kind of squeezes it, you know. So you have to wait at least 10 days. I found that out. So now, I don't put in another needle. I take out the one that's troublesome, that infiltrated, and I stop treatment. And I haven't had any bruising. As soon as it happens, I clamp, take it out, and that's it. That's all she wrote. Then I stop treatment. Turn everything off, clean everything up, go about my day until the next day. Big difference. But now infiltrations, the history of it, according to the average, happens once in a blue moon, supposedly. But then I come along. I've had 24 infiltrations thus far. 2 of them on my dime. Like, I inserted the syringe. One was at the clinic while I was in training before the surgery, which prompted them to listen to me and go in. After 22 infiltrations, that wasn't enough for them to hear my cry when I kept saying, there's something wrong with the venous. I feel pressure and that ache up on my shoulder. Okay, whenever I'm in treatment. Nobody listened. And now I'm going to explain to you what the problem was. There's a disconnect. And if I'm blessed enough by Elohim to go to this conference that they have every year, I've been invited to speak at, I'm going to talk about that disconnect between patient and her medical team, about them not listening or just brushing off. You know, I understand that I don't know everything medical because I'm not a medical professional, although I have been in the field. I have done nursing. And when my mom passed, I just couldn't do it anymore. You know, I was blessed to take care of her. She was in the same hospital or center, Parkway Medical Center, where I was staffed at. And I was on a different floor, but I was able to come down and see about her, you know, and check on her, and all the way till she passed. They actually called me when she passed. It was at 1 a.m., 1:05 a.m. Back then it was pagers. I got a page. And then I called, and I can't remember my co-worker's name. He told me that she had passed, and I called my pastor, and we all gathered up, and my pastor showed up. This was on a Saturday, and I think it was the 19th of November in 99. Was it? I can't remember the year. But my pastor and his wife and a few members of the church showed up. Not a lot, but this was right before Sunday. The church said was 1:05 in the morning, so we were there till about almost 3. And we had to go to church the next day, and we sure did. And the thing is, we had an all day and evening service that next day, it was men and women's service. The men's, women's was during the day, and the men's was at night, I believe, or the other way around. But yeah, we had men and women's. So we had another church that we had invited. We had dinners. We had food. I had to make, I don't know how many trays of home fries that I volunteered for. I went home. I did all that. Got my kids. They were little in, and I got them all ready for church. And we did that. We went through it. You know why? And everyone at church was like, they passed me the microphone. My husband did. He was my ex-husband. He's a pastor, and I told him I didn't want to speak. But guess what? He announced me anyway. So I remember saying that the pastor of the church, he spoke about how he had asked me or informed me that it would be okay if I didn't report to my station the next day, because I had a position at the church and it was vital to the ceremony and what we were going to do, and that if I didn't feel up to it, that was perfectly okay. Everyone would understand. But I told him, I said, but Pastor, my mom just passed. She's gone. She's in the arms of God, in the bosoms of God, I pray. My place is with him, so I could be closer to her as I'm close to him. You see what I'm saying? So I needed to be in the house of the Lord, is what I was telling him. That's where I was going to gain my peace and comfort. That was for me. But anyway, it was a beautiful service. Everything went perfect. Perfect. And then I knew it was nothing but the hand of God. And I did feel such serenity. And very happy that my mom was no longer suffering in the flesh. But anyway, after she passed, I just couldn't do nursing anymore. I couldn't, that love for it just, it didn't vanish. Like, I still feel strongly about nurturing and caring for others in my way, but I have a temporal kind of love for it. Like I have a natural temporal love for children. Like, I'm not that hovering type, never was, of a parent. No, you just aren't wrong. You're paying. You gonna understand what it was. It was. I mean, don't get me wrong. I love my children, and I will do whatever I can to help them with wisdom. Okay, but I am a strong believer in tough love. Is what I'm trying to say, and I can separate my heartfelt emotions for them when it comes to correction. Yeah. So, I don't know. But it served them well because they're all very independent and all successful. Of course, we always have one by the wayside. And even though he's still, he's not lazy. He goes out there and works for his money. He's just not as focused as the other three. But then again, he was the baby. I don't know what that means, but he was the youngest. I guess he was treated a little different now when they're real small, it's a different thing, but when they start talking and start committing acts again, you've got to put that to the side and start teaching and training. Yeah, from birth pretty much these days. But anyway, my point is that with all that I had gone through with my mom's death, and the dissipation of the calling I had for nursing, I fell back on my business management skills and had a little side jobs here and there, and little temporary jobs here and there until I found my place as became a branch manager for a staffing agency. Anyway, so which is that from there, that's where I had separated from it when I got this disease, and it progressed to the point where I couldn't work anymore. But anyway, my point is this: even though I've had certain I've had experience in nursing and understand a little bit about medical procedures, technology, pretty much I know a little bit of that world. It's a lot different today than it was back, 20, 30, almost, 30 years ago, 32 years ago. A lot different, a lot has changed, but I still understand the basics. Which is bedside manner, always listen to your patients, listen to your doctors, and if there's something you have a concern about or you don't agree with, put it on the table. It might be a medical reason why you don't understand and why you don't agree with it. And then on the same token, there might be something that patient knows more about their body than you do. It's teamwork. That's why they call it a medical team. It's teamwork. I'm the type of person, if you show me why, then I understand better. And I'm able to enhance that help, that treatment, because I understand from the medical point of view the importance of it and how it works. But if you keep me in the dark and you're just trying to bark orders at me, or you're not listening to me, we're going to run into problems. And guess what? I'm the patient, so I'm the one that's going to suffer. All the consequences. Well, I'm going to throw this ball right back in your court, because that's not how I operate. If I'm suffering, then I'm going to hold you accountable, because especially if I've tried to prevent that suffering or minimize it and no one's listening. So there's the disconnect. So I'm definitely going to speak on that. So anyway, so after I talked to Dr. Shammy about what I went through prior to the surgery, last surgery, he went and asked my nurse, Beth, to go get the report. He wanted to see the surgeon's report, post-surgery report. And standing up, because I was sitting there, he was standing up. He takes the report, and on the back of it, looking down, so I'll dots upside down. Yeah, like he's drawing upside down pretty much. He draws this. I don't know if you can see it well. See, there's my neck and shoulder, there's the arm and stuff, okay? So this is what he explained happened. This is the fistula right here, okay? Now, there's the arterial draws the blood, it comes out of my body into the machine, it cleans in. When it comes back in, all right, it's supposed to go through the vein, the arm, and down, okay, this way, and into the heart, okay? And the heart distributes it through the lungs and for oxygen and stuff like that. Excuse me. I have an itch. Anyway, what happened to me, the surgeon, what he found was, he found that this was pinched. Okay, it was a pinch point. So it was stopping the blood from going where it was supposed to, towards the heart. And instead, two things happened. Okay? It developed, the fistula or the vein, developed another route from where to travel the blood. And it developed what they call a branch. It branched off and went this way, but instead of going down, because it followed that vein or avenue of blood travel, it was going up. See? It was traveling from my arm. Instead of going down, it was going up. And that is what caused that pressure, that strangulation, was that force of blood through that branch. So the surgeon fixed the pinch point, blew up, expanded, ballooned, okay, the passage towards the heart, okay, so it wouldn't come up, all right, because whatever did squeeze through here went up that way, and then it finally got, the pressure got so much that it actually opened another avenue, another branch, and it went this way too. So I was getting hit, all right, twice, and all going up to the left side of my head, up through my throat, I guess carotid. And that pressure is what made me nauseous also, and because the blood wasn't recirculating correctly, and it made me vomit, and it gave me all the symptoms. So he opened that up. First what he did was he pinched that off, that branch off, and stopped it. Okay, closed it off. And then he ballooned this, okay, ballooned right here. So now the blood goes down to the heart. And that is what I went through. But I noticed that I want to have an ultrasound done, because when that pressure, when I was getting those headaches and that pressure built up and it was going to the side of my head, there was a little, like a breakage through the skin on my skull right here of little beads. Like they weren't, it's almost like a pimple, but not with a point or anything. It's just little beads, little tiny bumps, beads And that was from it, you know, breaking through the skin, that pressure. It's gone now, but I still get, every once in a while, when I lay down, I still get that strangulation feeling. And I notice that when I do my blood sugar gets high. I don't know if it's the blood sugar that's high before, because I'm pretty regulated with the pump. My A1C is, I think it's 5.5. I don't know. I just got my report. It's normal, and has been since I've gotten on Medtronic's pump, insulin pump. And my problem wasn't always real high blood sugar as it was lows. I had a lot of lows when I was taking insulin on my own, gauging on my own. But not with the pump. Now it's different. Anyway, I noticed that when these things happen, when I feel that pressure again, it's not as strong. It's not across my chest as much anymore. It's mostly in my throat and this side. I notice that my sugar is high. Whenever it happens, I'll look at my pump and it'll be like 170, anything above 170, and I feel that pressure. And of course I dose right away, and it takes a while for it to come down, because the dose that I take, it's, you know, it releases at a certain pace. And because I'm actually a type 2 and not a type 1, it's at a slow pace. You know, sometimes I would just want to take a syringe and just give me a straight shot of insulin to get rid of that, but I don't want it to be in the danger of going too low, of taking too much. And even though by now I pretty much know what to take, you know, I can gauge it a lot better. But anyway, so that's where we're at. So what I want to do next is I want to ask for an ultrasound for this, you know, for the fistula all the way up, even to my head, a CAT scan, if you will, just to make sure. So that's going to be my suggestion to them, and I hope they listen, because if not, then I'm going to go outside of the network and just get it done on my own. It's my life, you know. Like I said, I'm going to reach out first, and we're going to go from there. There's always going to be a disagreement, you know, between medical team and yourself and the patient. Patients, you should always do what you feel is right. Seek other medical treatments or advice whenever necessary, or even procedures, which is what I'm going to do if they don't listen. If they don't set me up for ultrasound and CAT scan. Post-op ultrasound and CAT scan, just to make sure that nothing's going on my left side. Okay, but I have a picture of an infiltration and what it looks like, and this is that evening of, or the next morning. Okay, look what that looks like. I don't know if you can see it. See that? Yep, that's venous and arterial. That was a double infiltration. She blew. They had to stick another syringe in. They went through with the treatment anyway, and then he blew. See what I'm saying? I don't do that anymore. If now that I'm doing my own treatments, if I infiltrate, and I've only had 2, one at the clinic before the surgery and one here after the surgery where I went too high up. Also, my venous deepens at the venous point. It kind of disappears almost. So it's hard to track where it's at. And that's even with the tourniquet. So before, I was always taught to feel for it here, and then I have a stethoscope, listen for the bruit and the thrill and all that, you know, feeling here. And but I noticed that when I went to the follow-up, I noticed the surgeon, he didn't go like this. He went like this. See what I'm saying? And when he went like that, and he squeezed from either side of the fistula, I could see it. I'm like, well, that's what I'm going to do. And I've been okay ever since. You know, I did that one infiltration where I just tried myself and went too high, too fast. You kind of just got to creep your way up slowly so you can track where your fistula is. And it's at a deeper angle, so instead of going up straight in this way, like I do the arterial with Artie, going that way because it's right there. Here I have to go in down and then land the plane. So yeah, it's a different technique, but when you're doing it yourself, you feel it better too, you know. But anyway, I wanted to show that to you all, and thanks for listening to me and my story. But if I could help anyone else on a journey, on this journey where anything is possible and not everyone is the same, you have to understand this your medical team has to not just only deal with you, but which is why, like a doctor, which is why they brush up on your record before you go in and see them, so they can recall everything that's going on with you in particular. But they not only have to deal with you in your case, but they deal with a whole lot of others too. And so we have to be a bit understanding and compassionate about that too, and really work with them. Don't give them a hard time. Just state your case politely. They respect that. They really do. They may not always listen, but then it's up to you to help them listen. Okay? And then when you do that, the more you prove to them that you're not just being an annoying patient or a combative patient, that you're serious about what you're stating, and you have a little bit of knowledge behind it, and you prove to them, see, I said so, and it is so, then they do listen. They start respecting your opinion more. Sometimes you have to help people to understand you. And that's really the bottom line. And they're no different. We're all human, you know. So, with that under our belt, that little bit of knowledge, you know, we can really work well as a team together and make them your asset, not your challenge. The disease is the challenge. The team should be an asset. Okay? I guess that's what I'm trying to say. But all in all, that's all I have on that note, on that topic. So now we're going to move on to the new chloramine testing procedure. It has changed. So I'm going to show you that next. Be right back. Okay, here we are at the chloramine testing. Let me go ahead and get you situated. Okay, well, you can see what I'm doing. Alright, so I put the sac in, early this morning, about 1:30 or so. And it's ready. It says check chloramines and remove the orange line. Okay? So, to check the chloramines, we have to remove the orange line. So, I've shown you that procedure already in the other video, but there's been a change. So, I'll show you what the new procedure is. Okay, we'll open this door. If you notice, I have 2 cups. Okay, this is the old cup, which is fine for what we're doing now, and this is a fresh, clean cup. Okay, which we will test our chloramine, our final chloramine in. Here's the test kit, test stick. So let's go ahead and get that open. Okay. All right. Get that ready. So, check chloramine, remove orange line. So, let's go ahead and clamp the upper orange and the lower orange. Okay. We're going to separate the lines, put the cover on that one. Okay. Ow. Okay. I got really big gloves because I kept trying to put my size on. These are Hubsters, extra large, and they just kept breaking. So I was like, look, maybe my hands are sweaty or something. It is hot out. Anyway, even though I've washed them and sanitized them. So now we're going to take, and you know the routine, we're going to put the line in the cup, we're going to unclamp, and we're going to hit go. And it's going to take a couple of minutes. It says dispensing on here. Let me show you. Okay. And it'll take a couple of minutes for it to do so. It'll make a click. So I'll go ahead and cut out this waiting part. There's the click, and there it is. It's coming out. It stopped, and it's telling me to reconnect the line. So I'm going to clamp this. Okay. I'm going to reconnect the line. Just keep it. Okay. And we're going to hit go. It's asking, did it pass? If it did, hit go. Or did it fail? If it failed, hit stop. We're not going to check it. We're just going to go ahead and hit stop and tell it that it failed. Alright. Then it says, continue, hit go, or drain the whole sack. Hit stop. We don't want to drain the whole sack. We want to continue, hit go. And it's going to tell you to check the chloramines again. And that's what we want. So, remove the orange line. So we're going to do that same procedure again. We're going to clamp clamp. This time in a clean cup. You could get Dixie cups or something. You don't have to have these. I just happened to be given these by the clinic when I graduated and was leaving. I got some supplies, and they included this in the box, so I'm going to use them. Alright, so clamp. Again, we're going to remove, disconnect the orange line, put the lid on that hose, and put this in the cup and hit go to let it know we've done that. And it says dispensing again. And it'll take a couple of minutes, it'll click, and it'll start pouring out. Okay, so we reconnect the lines. Let it clamp. Reconnect. Okay, then unclamp. Unclamp. I'll check. Second. We're going to stir it for a minute. Okay, after the minute is up, I set that down. I cover this, which I'm going to empty out. Okay. We're going to wait 20 seconds. 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6 1,000, 7 1,000, 8 1,000, 9 1,000, 10 1,000, 11 1,000, 12 1,000, 13 1,000, 14 1,000, 15 1,000, 1,000, 17 1,000, 18 1,000, 19 1,000, and 20. All right, so after 20 seconds, we shall do that window test. And as you can see, it is a go. It is golden. So we can now pass the chloramine. Hit go. And the batch is ready. Got 82 hours. Of time on this batch. See? That's good enough for 3 treatments. And then another sack will go in. So that's the difference. The difference is you have to fail the... Let me turn you around to me. The difference is you have to fail the chloramine test the first time around and then take it again. And then after swirling around a minute, you have to let it rest for 20 seconds. And then take a reading. Do your little window pane reading. And match it to the little chart that they give you to compare it to. Alright, and so that's the new chloramine testing procedure. So until the next one, until the next episode of my ESRD journey and on NxStage training, God bless you all. Take care of yourselves and one another. I mean that with all my heart. Love y'all in Christ. Bye.